Shannon is a 35 years old professional female rugby player, and she has a complete left ACL tears and torn meniscus. And her goal is to return to a competitive sport. ACL and meniscus tear are the most common traumatic knee injuries in athletes. So for the ACL function, it supports the extensive mobility of the knees, and it's most high incident in sports such as rugby, involving contact, deceleration, twisting, and cutting and jumping. And for the gender specific risk, female has a higher risk to get ACL tears due to greater acute angle and increased valgus stress. So the function of the meniscus is to low bearing, shock absorption, and then enhance the joint continuity. Uh, Meniscus is usually occur with ACL tears, condyle lesions, and mid MCL injuries. And for the classification, there are four types of ACL tears, as you can see. And 70% of the long contact ACL injuries is caused by doing wrong movement technique. And ACL and meniscus is often associate injury up to and injuries to the ACL and meniscus are associated with higher risk of developing osteoarthritis. As for the special test, the anterior jaw test is the most commonly used special test to diagnose ACL, and there are also Lyman tests and pivot shift tests. Other than special tests, we can also diagnose this with X-ray and MRI. As for the consideration for the treatment approach, we can consider the patient's age, the combined injuries, activity levels, as well as high instability.
Okay, when we move on to the major principle of rehabilitation for the ACL, the guys athletes from the day they get hurt to the day they are back in the game, it's like a personalized game. No more guessing with the calendars. It's all about checking off the right steps to play safe and play strong. So when we move to the early stage, we have to review the six critical dimensions to address the pain and swelling. Second one would be the range of motion. Third one would be the strength and the working gait and the prevent conditioning. And last one would be the psychology. So mid-stage emphasize the need for improving the muscle strength like CKC exercise and also the movement quality and the fitness reconditioning to enable the athletes to meet return to sport criteria more effectively and reduce the risk of secondary injuries. So the late stage of the rehabilitation, we have to considering the neuromuscular and physical condition, achieving 100% lean symmetry in quadriceps and hamstring strength is crucial, alongside maintaining the knee flexor extensor ratio over 0.6, utilizing the isokinetic and isometric tests to ensure the jog jump performance exists of 95 symmetry sets of foundation for movement quality. So we also have to consider the technical and the retraining, like specific the demand of the athlete's sport, like for shower would be the rugby, and the training loads. We had to make sure the activities at 90% of their typical weekly training load. So to generally say the traditional approach may not instead of just counting days and checking the off the knee impairments, it's crucial to take a step back and then move forward with the tailored and multi-factory strategy. We proposing the continuous assessment and follow up, taking the athlete's interaction with the sports and the environment into the mix, ensuring a more safer and more confident return to the game. So uh, let's move to Matthew.
As for the treatment option for ACL and meniscus, the conservative management is physiotherapist, and medication, non-steroidal anti-inflammatory drugs is used to pain management and reduce inflammation. As for meniscus, the approach is similar to ACL. As for the surgical intervention, the most for the ACL reconstruction, the most used graft should be the hamstring to utilize the patient's ACL. And for meniscus, the removal of the damaged part is one of the surgical approach. Other than that, meniscus repair is also another approach. As for the pros and cons, compared to the non-surgical one, the surgical intervention can more benefit in improving stability and medical protection and technical advance. For the cons, patient may face surgical risk and the cost and recovery time will be higher. As for the rehabilitation protocol for the conservative approach, there are contained 4 phases, as you can see here. As for the post-surgical rehabilitation protocol, it contains 5 stages as shown.
So in the debate on how to best treat the athletes with ACL injury, there's lots of to consider. The surgical reconstruction is not just about getting back on the field. It can reduce the risk of further meniscus damage and may prevent the osteoarthritis down the line. But it's not the only way. Non-surgical treatment has been shown to work well for some, allowing athletes to return to sport with satisfactory outcomes. Yet, no matter which routine is taken, the risk of additional knee injuries and osteoarthritis looms. And here's the kicker. We are still in need of high quality research to truly understand the best approach, as current studies leave us with more questions than answers. So for now, each athlete's path to recovery must be carefully weighed and personalized. So when we are considering the case study for the Sharon, if she's goal is return to competitive sport, surgery often become the more cornerstone of treatment, would be the best option for her, because for this protocol can restoring the knee stability and crucial element for high level of performance. So let's move on to the evidence base. Our objective is care to design a comprehensive, aggressive rehabilitation strategy tailored specifically for Sharon. And like when we move to before surgery, we set clear goals for Sharon physical and psychological readiness, boost her cardio fitness, muscle strength, knee mobility, while ensuring she receives social support needed to tackle surgery mental issues to maintain strong mindset. Right after surgical, focus we focus on managing pain and swelling and cryotherapy, compression and elevation, while gentle mobilizing the knee and starting weight bearing as tolerate to set the stage for recovery. In the early rehab for 2 to 6 weeks post-operate, we are advancing range of motion strengthening muscle with the isometric and cold chain exercise introduced MNEs if need and training for proper gait mechanics. During the mid stage of rehab, we are upstream proprioception work, beginning sport specific drills and continue psychological support to tackle any mental issues. To the late stage of rehab, it's all about meeting return to spec criteria with advanced drills and functional tests to boosting the confidence and carefully managing the meniscal repair to safely rebuild the sport-specific skills. So after the 6 months beyond, we are strict to ensure the Sharon passing all assessment before return to the rugby, while focusing on injury prevention and long-term knee health.